Hey, Deanna.
Yeah.
Deanna.
Yes.
Nope, there wasn't a link sent out on email last night, so I don't know if people all have the old link or not, but I'm on it. But
I don't know if I actually had a little bit of trouble getting on today too because I clicked on the old link, so I
okay,
had to go into Zoom. So I don't know if there is a new link.
okay,
Did I don't know. I'm sorry.
that's okay. I'm just letting you know.
Good morning, everybody. So Chrissy just brought up a good point. I might, excuse me, I might real quickly try to grab a link and send it out to everybody. So actually, Deanna, if I let you start us off, I might do that while
Sure.
you're getting started, if that sounds okay.
Yeah. Good morning, everybody. And we might have some people join in a minute because I know there's two links out there. I got two links coming to my email this morning, so I was struggling myself. There's more people joining. All right, so as far as my piece of the meeting today, I really just have a few reminders more than anything else. And one of them was in Sarah's update last week. I wanted to first off just mention a lot of what I say on the meeting is like trends that I see whenever I QA notes or feedback I've gotten from case management. And one of the big things I got Angie messaging me, did the meeting link change? I guess we're all having issues with the meeting today. Um, one of the big things that I've noticed with the nom knock is that at some point when I first started, I know that it was the process of the nom knock was to sign it and leave it in the patient's folder, and then the DCO clinician was going to upload it. However, shortly after I started, that process did change, and now it is the therapist's responsibility that gets the nom knock signed to get that uploaded into the chart. I am still seeing oftentimes that it is falling on the DCO clinician to upload that nom knock. I know some people have reached out to me and said that there's certain areas where they're not getting service. That would be the best time to use your cam scanner app and take a picture of the nom knock. Always leave the signed nom knock in the folder, but make sure that if you're a PTA and you're getting it signed and the DCO is in 48 hours or a week from now, if you get into a service area where you can get it uploaded, please add that as part of your visit. We are supposed to be checking the episodes tab every visit. The reason for that isn't just to see when that patient's discharge is falling, but also because we are supposed to be, as part of a condition of participation, discussing discharge with our patient and kind of giving them an idea of when their discharge date is going to be. That is one of those regulatory items that we do have to do. So I just wanted to ask, is anyone having issues with uploading nom knocks? I know I've gotten quite a few calls and text messages recently. Mostly I've noticed that it's newer staff. So I've tried to make sure that I really show people when I onboard them now how to go about getting the form signed, how to go about using the cam scanner app to take pictures and upload it into the chart. But please, if you have any questions, we want to try to take some of that bulk paperwork um, off of our DCO clinicians as much as possible. And that's just one little piece of the puzzle that they just don't have to do if we can help them try to get that in the chart. And really, it is supposed to be in the chart when we get it signed. It is perfectly fine to get the nom knock signed a week ahead of time. If you know that person is coming up for that DCO, go ahead and get it signed and get it in the chart if you notice it. The other thing to note about the nom knock, and I'm saying this, some of our older clinicians know, but I am going over it again because we have gotten a lot of new staff recently, and hopefully we're about to get a lot more. So, make sure that not only do we have the dates reflecting the 48 hours, but it's not just a notice of discharge. It is the giving them the option to appeal and giving them the information on that sheet of paper so that they can appeal if they want to. And I have a chat from Kathy Zacob. What if they cancel the last visit and we can't reschedule? So I have been told that if we call and tell them and discuss it with them, that I've seen that happen a few times. Hopefully that's not happening too much. And that's also why we were hoping to maybe get it signed a week ahead of time now, if you can, because then we have multiple opportunities to get that form signed. Call them, discuss the discharge with them, direct them to the folder, explain that we are discharging on this date. Also tell them, please open up your red folder and can you see if you do feel like you don't agree with this decision and you would like to appeal the decision, all of the information you need is on that form. So that way we are talking to them about discharge, we're notifying them of discharge. And correct me if I'm wrong, because I may be, but if you are talking to them and telling them when the discharge is, I believe you can go into the forms and put their initials and make a note in there that says it was verbally discussed that day. Am I correct? I think I am, but I'm
Yes.
making sure. Okay. I don't want to tell people wrong.
Yes, you're absolutely
what
correct.
I-
And you,
Okay.
and you can write on there, like I've done it before and I've write verbal discussion had with patient. I make them recite it back to me that they understand that they are being discharged in 2 days from now or what have you.
All right. So yes, you can call them and you can verbally talk to them about it. And then you can put that in the sub forms, the forms, nom knock. Another thing, I have gotten a couple questions from newer clinicians. It is not a discharge from just one discipline. It is a discharge from all of home health. So we do not have to have multiple signed, but we do need to have that one signed before they come off of all of home health services. Any other questions about the nom knock? I know, another thing I wanted to mention too, we did have someone called and, said that they had forgotten to get it signed, but it was at one of our buildings out at our outpatient line of business that provides home health under outpatient. And so, I mean, in that circumstance, I just asked her to call the building manager and see if maybe the building manager there, since they were there more often than her, could go and get it signed, and that seemed to work out. If you guys do ever have any questions regarding anything, reach out, me, Annie, anybody, case management, we're all here to help. All right. I also found out last week, and I think that we kind of found out, I just saw Danielle joined, but Danielle called me and said that Essence in particular is kind of holding off on giving us authorization if our CC note, our assessment summary and frequency is not in care coordination. And I want to remind everybody that we are hoping that you're putting it under the episodes tab care coordination, not inside of the eval care coordination. I know that's confusing. It confused me in the beginning. The reason being is because if we cannot provide the requested frequency, it's not inside of our documentation. It's in a CC note outside of the documentation. So it's not that they're denying auth if we don't have the assessment summary and frequency in. It's that they're not giving it to us until we get that assessment summary and frequency in. So I spoke to Annie yesterday, and I also know that they do not typically give us authorization until the visit is complete and submitted. However, I think that if we can make sure, even if you can't complete your visit that day, or I'm sorry, if you can't complete your documentation that day on that visit, if there's any way you could maybe put that assessment summary and frequency in that CC note, I don't know if that would help. Danielle, can you chime in? Do you think I know they have to have their visit submitted, but maybe just to kind of give a blurb of what we're treating this patient for and their frequency request, inside of that care coordination. Do you think that would be helpful?
I do, yes. Even if it's not submitted, as long as there is some blurb in there, like you said, yes, we'll be able to send off that auth request.
Okay. So that's something to think about for our late documenters. If you maybe put your assessment summary and your frequency request, please, in the care coordination note, and that way we can go ahead and try to get that off. Also, as far as processes go, I've gotten feedback from some of the QA, some of the case managers that even though we need that verbal order for our Humana and our Carillon insurances, and then sometimes also to continue with others after reevaluation, that some clinicians are waiting until the visit is sent back to get that verbal order. We are trying as much as possible to please check your insurance and authorization sheet. Please make sure that if you need a verbal order, you're calling that day. If you are having issues getting a hold of a physician, that is when you will reach out to myself or Annie. And I know that there has been times where we can't get a hold of somebody for multiple days, and that's obviously not your fault. But we want to make sure we do something. We have our marketing team that can sometimes take orders to the doctor's office. We also can fax the orders to get a written signature on them. We've got to do something, because if we don't have the order in place for those particular insurances, we will not get auth. They do expect to see the name of who you spoke to in the comments section, and the frequency and what discipline it is. You can also add that information when you submit your auth request. You can put that in the little box that's next to the authorization request. I have found that helpful myself. It's not mandatory. You don't have to put it there, but as long as they see the frequency, who you spoke to, and what discipline it is, then we can get auth. The other thing to mention about this, which I know leadership had discussed, because at some time they were trying to figure out how to make it easier for us to obtain auth, even if we don't speak directly to the doctor. If you speak to someone at the doctor's office, you can put in spoke to so-and-so at Dr. So-and-so's office regarding continuation of OT or PT or ST for 2-week 3, effective whatever day
Deanna.
you speak to them. Yes.
There is quick text in the comment section for
Oh.
the orders
All
for
right.
them
I
to
didn't know
use.
that.
And then they will, if they follow that, then everything should be there.
Fantastic. There's quick text. I didn't know. So just use those quick texts, and you do not have to actually talk to the doctor or wait for a return phone call for those auth-based insurances. I don't know if anybody has any questions about that. I know that we've been trying, they trialed different orders to see if it would work. And from what I understand, we haven't really had many issues or much of any issues with getting the auth that we need by doing it that way. So does anybody have any questions? I have a question from Jeanette. Which quick text, please? I looked in order, but I was unsure. Since I don't know, I'm going to have Angie answer that, because I don't ever use quick text except for with the home health.
I don't know the specific name. I can look at it, look in an order, but it says authorization in the
It
label.
says for authorization change order.
Yeah. And if you're not seeing that, Jeanette, let me know and we can get together and I can see what you're seeing.
Okay, thank you.
Uh-huh.
All right.
And then going back to the non-knock, somebody had asked a question about what if we're having trouble getting it completed electronically? And that can happen sometimes. I know, especially for the laptop, sometimes it's difficult for the patients to try to sign on the mouse pad. So it is okay to complete the paper form version of it that's in the folder. And then you would collect a picture of that, and that can be uploaded to the patient's chart. So that would be the way around that if you're having trouble. But if you're struggling with anything like that, let us know and we'll see if we can try to get a little tutorial to you, or maybe there's something going on specifically with your device that needs to be looked at.
I know some people have also had issues with, it's hit or miss, but I have had a couple clinicians reach out to me having issues uploading that AW home health patient update form for Essence 2. I've had to direct them to Scott because I'm not very IT savvy. So if you are having issues with, I believe when we got the newer devices, it started to become, there was some people who were having issues with that. So if you do have any issues with uploading that form, let me know and I will, or you can reach out to Scott. I don't know what it is. It says that there was like a damaged, it was a damaged file or something like that. And I don't know if they had to change it over to something else, but if you do run into that issue, please let us know. And I am all finished.
All righty. Okay, so with it being October, we just want to give a shout out to all of our physical therapists and physical therapy assistants for their month of recognition. Keep an eye on your email. I do believe there's some information that's going to be coming about some recognition for you guys. But you guys are amongst the allied professionals. You're the ones that tend to be the most recognized, and people generally kind of have an idea of what it is you do, but it goes so much deeper than that, just beyond that basic moving around and getting stronger. You guys provide holistic care, and we really appreciate the service that you guys do. So happy Physical Therapy Month. I wanted to give a reminder about the referral bonus that has increased recently. So if you know any clinicians that would want to join the team, it's literally every discipline there between nursing, PTOT, and speech. If a full-time person becomes hired based on your referral and they're with us at the 90-day mark, then that next pay period, you would get a $2,000 bonus. For full-time, part-time is $1,000 now. And then also our caregivers for the home care side, there's bonuses for referring those staff members as well. So just something to keep in mind. And then speaking of new staff, here are some of our newer people who've joined our team. So we've got Carrie, an outpatient. She's an OT. She's going to be based primarily out of Clarendale. So I know they've been looking for that role for a while. So we're happy she's on the team. And then we have Chelsea Harris is going to be a PTA for us in Missouri Home Health. And she's going to be doing that South County, South City kind of area. So we're really excited for her to get started at the beginning of November. And then Marilyn, some of you guys may have spoken with her on the phone already. So Marilyn is a new administrative assistant that's going to be out of the U City office. We still have Shelby Neninger with us. She actually just is promoted and is going to be doing some higher level assisting to make the job for the schedulers and for intake a little bit easier, and where they can focus on the clinical aspects of things better. So we're excited to have her. I'm not really aware of anybody that's left us recently, which is wonderful. Okay, so a message for the assistants with us, for OT and PT assistants. As you know, there has to be that communication between you and your supervising therapist. And I'm not really concerned with anyone that the communication is not happening, but we just really want to encourage that you're putting in a CC note, because not only does this help your therapist who might not remember right before they're going in to see that patient what it was you guys discussed, they can just look back at the CC notes before they go in. But also it helps the case managers to know what's going on and to help with the care planning for the patient. So what we're really looking for are those 3 Ps. Is the patient progressing? Are they participating? And do you feel that they're prepared for discharge or not? So just it can go in the CC care coordination section of your visit note for the day. If you put it in there when you turn in your visit, when you submit it, it's going to ask if you want to notify anybody. And then it's good to notify your supervising therapist and the case manager, and then it'll always be there for them to see.
I can just read the note.
Okay. So for our evaluating therapist, it's very simple and straight to the point. I think there is going to be some more information coming about trying to make it a little simpler. I think there's some talk of trying to make some quick text to help with this process, but we really need the therapist to discuss, to make some kind of communication with the case managers before discharging patients. The best way to do this is just as soon as you have that inkling that the patient's going to be prepared for discharge, to send a CC note out. And again, it can be part of the note that you're completing for a patient that day, or you can go into the patient's profile and put it in under the episode tab. But the reason for this, other than the obvious, is just that we've said many times you'll have discharges put on your schedule. It doesn't necessarily have to be a discharge just because that's what it's listed as. It gets listed as a discharge. That literally just means this is the last ordered authorized visit for your discipline. So they're just trying to make sure that supervising therapist is out there to kind of determine what's going to need to happen next. It could end up being a reassessment, a recert, whatever the case may be. But that's why we need that communication with the case managers. They can get that visit changed for you, and they have a little bit more insight than us when we're busy in the field taking care of people, as far as when is the cert coming up? What has their insurance company been showing? Are they going to be agreeable to give us more visits? You know, what have the other disciplines been saying as far as how the patient's participating, et cetera, et cetera. So that keeps everybody on the same page and make sure that we're not discharging patients too early. Sometimes when we're looking over charts, you know, strictly from that administrative viewpoint where we haven't been out to see the patient ourselves, but that's how regulators and insurance companies, CMS, that's how they're viewing our charts as well. And we kind of find ourselves going, I wonder why we discharged this person. There are some goals that weren't met yet, and they seemed like they were participating. And the best answer we can kind of come up with is sometimes it's just because it was listed as a discharge visit. And so people were kind of just completing the visit that they had on the schedule. So we just really want to make sure that we're working with the case managers, trying to determine whether those discharges should be happening now or whether we should be getting more care for the patients. I apologize for my voice. It's cutting in and out on me a little bit. Okay. So, and by the way, Deanna, if you see anything pop up in the chat, will you let me know? Because I can't see it the way that I have it sharing my screen right now. Thank you. Appreciate it. Home health nursing. So just wanted to throw it out there. If you have a patient that seems to have a skilled need for nursing, it's okay to reach out to the case manager and we can see if we can get that nursing eval requested. Things that we're thinking about are medical conditions they might have some lack of knowledge of, you know, especially like the CHF, diabetes folks, those chronic conditions that we know make them prone to go back to the hospital, but also new symptoms that pop up, you know, maybe like redness or swelling, wounds that weren't present before. Anything like that is a good reason for nursing to become involved. And I know that we've all run into situations where it's PDGM and we won't be able to get the nurse out this cert period, or the patient refuses it, or we can't get the order for it, etc. But most of the time it is something that we can do. So if nursing hasn't already been ordered for the case, we don't want you to feel like it's something that can't happen. So if you think it's something that the patient would benefit from, please reach out to the case manager or myself and let us know, and we'll see what we can do. But we do have nursing staff available to help. So just something we wanted to throw out there. This is going to come up mostly for the OTs with us, but it does happen sometimes for physical therapists as well. So I wanted to throw it out there for everybody. When you're going to have Missy or home health aide be part of the care plan for a patient, people are doing pretty well with getting the orders for it, just like you would get orders for yourself or any other discipline. But there's an additional step that has to take place that's letting Missy know what she needs to do with the patient. And where you find that is under the patient's episode tab. There's a button called Daily Tasks. It's one of those little blue buttons towards the top. And when you click on it, you're going to choose Shift 1, and then you're just going to pick what tasks you want her to focus on with that patient. And it's a pretty big list, but the only ones that you would be selecting from are the ones that have home health aid in front of them. So it's under the column that says group, it will say home health aid. That's a shorter list, and you want to pick from that what would be appropriate for her to do with the patient, because technically they want a therapist making that determination, and then Missy is going to follow the plan that you guys set up. So there's talk about effective dates and periods and how many times a week. Off to the right, you don't have to worry about any of that because you're taking care of it when you're getting the auth and the frequency for Missy, but you just need to go in and select what tasks that she should have done. If anybody has any questions or any trouble with that, please reach out. Okay. I wanted to touch base on our value-based purchasing changes that are going to be coming in 2025. You guys are going to be hearing more and more about this. And I do want our assistants to hear this too, even though they're not going to be completing OASIS. You guys are the ones that are treating the patients. You guys are the ones that are really pushing to get the patients the progress that they're making during their episode. So I think it's important for you guys to know what's coming too. So the big change that's coming up is that CMS, how we get reimbursed is going to be based on the progress that we're demonstrating with the patients. That's the biggest change that's coming. So what that means is we really have to be careful about how we're documenting when we're completing those OASIS visits so that we're taking credit for the progress that we're making with people. We see it often where we can see the progress in the person's assessment summary that they're putting in, but then when we look at the OASIS scores, it's not really reflected. So there's going to be a lot of education coming to help all of us get stronger in that. So starting in 2025, the GG codes section of the OASIS is going to become really important, as well as the respiratory and the medication management OASIS questions. They're actually going to have a little bit, those two are going to have a little bit of a higher weight coming in 2025 as far as how we're judged on how the patients are progressing. So I think most of you are aware that SHIP has already been reinstated. So whenever you're doing your OASIS visit, you're supposed to hit that SHIP button before you submit it. And it's there to help us to try to make sure that we're answering those OASIS questions accurately. Something new that's coming is that SHIP has just more data than you could even imagine, really, when it comes to OASIS. So there is what's essentially like a scorecard that we can pull up for each clinician. So it's going to help us to see, is there anybody that seems to be struggling with certain questions? Is there anybody that doesn't seem like they're hitting the mark compared to the peers or compared to nationwide? And we know you guys are excellent clinicians. We don't have any concerns about anybody not providing excellent care. So we just basically are going to be meeting up to try to talk about how can we help you to get this reflected in the OASIS as well. So I am going to be meeting with all of the evaluators individually. It's going to be starting next week. It'll take me a little while to get to everybody, but I'll be seeing a few people each week, kind of going over that scorecard, answering questions. Like I said, there's going to be a lot of education coming about the CMS guidance on how to answer the OASIS questions. So what do these changes mean? We don't need to change the care that we're providing. We know that you're taking excellent care of the patients. It's just going to force us to be more mindful of how we're documenting in the OASIS. And for our assistants, you guys are already doing an excellent job. But when it comes to those two I was talking about, respiratory and medication management, it's going to make it all the more important to make sure that you're making sure that your patients are comfortable with those items, that they're making some progress in those items, that you're touching on those. If you think somebody's really struggling with medicine management, again, maybe we need to get nursing involved. You know, is it more of a OT, fine motor, or speech therapy kind of processing issue, or is it just a knowledge of what the medicines are for, or why they're important? We want to make sure that we're getting them whatever they need so that they're showing progress with their medicine management. I just want to encourage everybody. It's already happened for me. It'll probably happen even more going forward. Please keep an open mind as we're getting this education on OASIS. You might find out that you've been responding to some of the questions differently than CMS has been intending. It's okay. We're all learning. The OASIS was written by the government, so they think they're being clear, but it's not always that clear. I kind of compare it to taking a preparatory course for the ACT. You kind of have to do that if you want to be successful on the ACT. So we're basically just going to be studying the OASIS a little bit so that we're successful when we're answering those questions. But the big one I find is medicine management. If somebody's balance or mobility is impaired, you're not going to be independent managing that, because at some point they're going to have to be able to get to their medicine, and they're not really safe to do that if their mobility is impaired. So please, I just hope no one will be offended or feel defensive. We're really just learning what CMS is intending by their questions and trying to answer that appropriately. And then we have SHIP, but also McB. I know we've all seen those big long paragraphs in the CC notes. Those are two things that we're using to try to help us to prepare for this time, to help us to be successful. If anybody has any questions about what's coming, any concerns, please feel free to reach out to us. And like I said, I'll be getting with all of the evaluators individually. And then I believe that's what I've got. So let me stop sharing. Okay, and then I would, oh, I see a question. Should we be putting in the notes, does patient own medicine, family setup, pill planner? I'm not sure, Kathy, what you meant about does the patient own, but is it good to be putting in information about their medication setup? Absolutely. You know, does family help with it? Are they managing it themselves, or do we have any concerns? Does their own medication? I got you. Sorry about that. Yep, that's absolutely a good thing that that's a good thing to note in your intervention. We'll all have medication goals and interventions at times that we're trying to address. So that's great information to be putting in there. Absolutely. And definitely if you have any concerns, letting the supervising therapist know and or the case manager know, so we can see if we need to get any additional assistance in there to help them with that.
And if you guys are ever
So I wanted
struggling
to open
with
it up.
treatment ideas on how to accomplish those interventions that have medication management, I have noticed as a QA that people put performed at start of care, but it doesn't give a whole lot of information, and that's not very skilled if you're just saying performed at start of care on the intervention. We need to give a little bit more information. Maybe the facility manages the meds, but there are ideas out there on how we can try to at least, I can't guarantee that those OASIS scores are going to change in the end, but we have things in our tool bag as therapists to make sure that we can work on different things to help with medication management, with dyspnea, with, you know, cardiovascular goals and interventions, CHF. We should be managing our patient's diagnosis, and there are ideas out there. We can do things to help them. Now, we can't guarantee that the scores are going to improve, but if you ever need help with ideas on how to treat and how to perform the interventions for medication management, CanTime's great because it lists the medications in there and it gives you almost like a pamphlet of information that have interactions, side effects, contraindications to taking the meds, you know, all of those things. So please let us know if you need any assistance with providing those interventions that are on your plan of care.
And like Deanna was saying, home health is such a special calling because when you're going in there by yourself, you're a therapist, you're you're a PTOT or speech therapy practitioner, but you're also just a healthcare practitioner that's going in and looking at this person and saying what needs to be done to keep you here safely. So we use different lenses that we're looking at people through, and our documentation kind of encourages us to look at people through those different lenses. And while we all have that basic knowledge, we don't expect that you can provide nursing care or another discipline's care to them, but there are therapy related items for all those things that Deanna is discussing that we can do. And when it comes to medicine, it might be being able to visually identify some of the medications. It might be being able to physically get to access your medication safely. It might be being able to open the container safely. Any of those kind of methods are things that we can help with as therapists. And if you feel like you have somebody that's just not understanding their medicine, it is trying but is not compliant with how they're used, doesn't understand what the medicine's for, that's something that we might need to get nursing involved in. It's not that you necessarily have to be able to provide that total intervention yourself, but it's being able to recognize it so that we can get that amended. That's the important thing. And then I wanted to ask, what questions do people have? It can be about something from the meeting or just some other question that you wanted to open up for the group. I did want to say I apologize. I did want to be going over some cases, but I had a feeling that this meeting was going to go a little bit on the longer side. And so I'll be reaching out before the next meeting to ask if anybody has any particular cases they want to bring to the table. But that being said, does anybody have any questions for the group?
Yeah, I had a question.
Sure, Ellen.
It's about the incident report forms. If a
Okay.
patient has a fall and like the check boxes at the top, when we click fall, and then it says, was it witnessed? Is that regarding, was it witnessed by us, the agency, or was it witnessed by like a family member, say? Like, was it witnessed by anybody or just was it witnessed by us?
That's a good question. So if I'm remembering correctly, and I would, encourage Angie or anybody to jump in if they feel they need to, but I believe it's really, is it witnessed by anyone? Because as you go down the
Okay.
list, you can specifically note who it is that witnessed the fall. So that basically, we could reach out to that person and ask questions if we need to.
Okay, good to know. Thank you.
Absolutely. Any other questions? And of course, if it's something you don't feel comfortable asking in front of everybody, just please reach out to me after the meeting.
I have one more
So
quick
what I would do
comment.
now is just,
Sorry, I just
oh,
got a
sure.
text message from Aubrey. She said, please remind everyone to check your corrections. Sorry, got a frog in my throat.
Okay.
Please check your
Yeah.
corrections. Please look in there. We have things that are over a month old that are sitting in correction mode. So today I'm gonna kind of go into the therapy portion of it, and I'm gonna start sending out messages to help grab that, but please look at your corrections.
Mhm. And the simplest way is just from the home screen on Can Time when you first log in. Just below a little bit, it's going to list, corrections that are outstanding. So that's kind of your box to go in and check and see what's in there. Mhm. We have seen improvements in that. So thank you, you guys. I think there are some people that are just struggling to get things turned in. Oh, I'm sorry, what,
Can we
Ellen?
make sure everybody that does sends back corrections actually tags it as a note? I know a lot of people do, but there's been times I've gone back into like the episode tab, into the schedule, and I've seen my notes read, and I click it. I'm like, oh my gosh, there was a correction that I didn't know about. So yeah, we could always get like messages as tasks or just a message of a correction. That would be great from everybody.
You mean basically where where your visit is basically resent to you and you're going to need to make the correction and then resubmit the note?
Some
Yeah,
of,
like the notes sent back to us.
Okay.
some of those, I think that's an extra step for the case managers. And so if they're busy and they're, like going through a bunch, they may not actually send it back or send it as a communication note. But and it should always show up on your dashboard. There's a widget, QA notes under correction. And watch those numbers, because if you get anything returned to you, it's always going to show up there.
And
So I don't know that
draw,
you're always going to get an office communication note with your returns.
And I know that it is also different if you're getting an Oasis QA versus a regular eval or a regular visit. It is a little different in the process of having to send it back. I don't QA Oasises, but I learned that through some of the case managers. So
and sometimes we have issues where when the entire visit is sent back, especially if it's something that's not really needing to be changed within the visit, people might go in and make the correction that they need to make, but then they're forgetting to or not realizing that they need to resubmit the whole visit. And so then it can delay their payroll, and then also the case managers aren't sure that the correction's been made to go back in and check it. So I think that's an excellent point to bring up, Ellen. I think that would be a good thing for us to kind of look at the process for. But what I would leave everybody with today is just to make sure that you're looking at your corrections bucket, so to speak, on the homepage, because it will show you whether the visit's been sent back or not.
and remember, after that 8 a.m. The Tuesday before payroll, there's really no guarantee that we can approve that, because we see so many people just mass submit all Monday evening. And it's just too much to have to go through. So remember the 8 a.m. cutoff on Tuesday before payroll, please.
It all kind of comes back to just really shooting for that 48-hour turnaround on documentation. That makes the whole process smoother. And if you really feel like you're struggling with that, please reach out. And I've probably already been reaching out to you, trying to kind of make plans and arrangements for that. But I think Kathy might be trying to ask a question.
Yes, I was
Oh,
just,
sorry.
go ahead. Okay, so if we send like, for instance, I had an issue where I couldn't finish the notes because the interventions weren't there. And I talked to the OT and they're like, it's there on my end. And I sent a note to the case manager, but I never heard back. And so like, it would have been just super easy if I would have known it got taken care of instead of me. I had to wait almost another week before when I saw the patient again, and I went in and then and I was like, well, I could have finished those notes earlier had I known that it was fixed. So if we send something, can somebody just send back like we got it fixed or something, just so that it puts a bug in our ear? I mean, we
I
have,
think we try to.
it's hard to keep up with. I know it's hard for us to also keep up of what needs to be finished, and we're like, oh, look at all these notes that I can't get finished. I sent a message and now I don't know. So it just gives us, and like, instead of having to keep going back and checking, did it get fixed? Did it get fixed? That
Sure.
Oh, it was fixed.
And I think
That's
I
a
know
lot
what you're
more
talking
for
about,
us.
Kathy. So I'll apologize. I think I might have been CC'd on that, but I think that there was some issues. Something happened and all the interventions got taken out or discharged. I don't remember what it was, but in that circumstance, really there was nothing. I apologize that you did not know when it got fixed. I'll have to look back on my emails and see what was in there, but we make mistakes
Fine.
too. So
Right.
it's a
And I
lot,
just bringing it
especially
up,
on payroll
just
week.
like, right. And I know that was then I had to go back and submit 4 notes then, because like I had talked to the OT week 1, and then the week 2 it wasn't fixed, so I went back to him, and then by the end of week 2, then that's 4 notes that aren't done.
Yeah.
And so I'm sending it up further up the line, and like, that's a lot then, that I'm like, oh my gosh, now I have to go back and redo all.
I know. I totally hear what you're
Sure.
saying.
So
It's
kind
a
of a
lot.
good reminder for us and for the evaluators if something like that's going on and we get it corrected to let the assistant know so they can go in. A majority of the time, those issues are sometimes it's just that the documentation isn't finished and something wasn't turned in time. But the other thing that we catch a lot is recert. Whenever a patient has to be recerted, basically all the orders that came before it are nulled out because the doctor is basically approving things for that 60-day window. So then we have to basically get all new orders coming into the next cert period. So what that means is we have to, even if the care plan isn't going to change, it has to be moved over into the next cert period. So what we'll catch a lot of times is if a discipline wasn't the one to do the OASIS for the recert, they might not catch to update their goals before going into the next cert period. And so it's not a terrible fix, but if it doesn't get caught, then it can linger. So, but again, if we catch that and we fix it, we need to let the assistant know so they can go in and finish their documentation for sure. And then Jeanette, did you have a question?
I did, Annie. Yeah, I was curious, since we were talking about corrections, I decided to look at my dashboard and see if there was anything. And there was a rock. And what's the expectation on the resumption for the goals tab? Because I had, I guess, texted the QA, my skilled care provided, and they include that blurb in the assessment summary, but then it was sent back saying that that needs to be documented under the goals tab. So I'm copying and pasting and it just kind of seems a little redundant.
I gotcha. That's an excellent question. I might have to get back to you on that because I know the interventions aren't listed like they are in certain OASIS assessments, like they are in an evaluation or a regular visit. But it sounds like for the resumption of care, the goals are present that can be documented against. So I know there's a lot of I know there's times where it feels like we're having to repeat ourselves, but we definitely want to make it as clear as possible that we provided skilled care that visit and we weren't just completing the assessment. So that's one of those big reasons why we get visits denied by the insurance companies. So when they're putting in the assessment summary, or I'm sorry, when they're putting in the blurb about the interventions that were completed, it would be good for that to be put in the goals. That might be something for us to talk about though with QA. If you have a QA on that visit, that might be something where they're needing to help with populating that. I'm trying to think. I don't think Lindsay's on here to verify that. Angie, do you have any input on that?
Is that regarding the goals tab
Mhm.
under the rock? Yeah, so I mean, the purpose of that is we need a response to whatever skills you worked on. We need that response to that skill performed.
But if they have a QA with them, is
The
that something
QA
that the
should be
QA
documenting that.
typically?
Yeah, they
is
should be
putting in?
communicating that with the QA and the QA should be entering that.
Okay.
Mhm.
But under the goals tab, are we putting our progress toward goals or are we putting interventions? Because it's kind of seemed like they wanted the interventions provided during that visit documented under the goals tab, or is it more just the progress toward goals?
It's just the progress towards that goal.
Yeah, the goals would always just be basically the patient's response. Do they need further training? What level of assistance are they at? Just that really simple, basic.
Yeah, because
simple
you're
update.
documenting in your visit note the skill that you performed. So then under goals, you're documenting their response to that skill that we performed.
Mhm.
Okay, that makes sense.
And where they're at on, going towards that goal, kind of like what Annie just said, if they need reinforced education or, what level they're at, if it's a physical skill that you did, where are they at on that?
Mhm. Jeanette, that sounds like that might be a particular one that would be good to look at. If you want to shoot me something in the chat, or if you feel comfortable saying, or send me an email or something, I'd love to look over it.
Of the specific visit, is that what you're talking? Okay,
Yeah,
I just
that
resubmitted
specific
it.
rock.
Yeah, sure, no problem.
Annie, you should be able to see it if you go in the field chart. and under that dashboard.
Because
that
it'll
you
have just
be
been
able to-
submitted recently. Mhm.
It'll say
I'll check it
correction
out.
notes submitted.
Melissa Lewis asks, is there a yearly compliance training on all of these processes? We do have our skills training that we do yearly. However, as far as compliance training on Melissa, I don't know if you mean everything that we talk about on these meetings or
Well, it's a lot of processes here that we're talking about. And if we want to be compliant and everybody is doing things across the board the same way, I'm just wondering if there's a compliance training yearly, it may be top of mind for everybody if we're required to do bi-yearly training or a yearly training. And I just think that, it would help everybody because this is a lot to digest.
yeah, home health is a lot, and there is a lot of autonomy there where we have to take responsibility for getting things uploaded and making sure, when I worked in skilled nursing, I didn't have to deal with a nom-knock. I didn't have to deal with a HCCN, or an ABN because we had social services doing that. I didn't have to, check which visit before discharge because I didn't have to worry about all of those things. But under home health, whenever it's us going into the patient's home mostly, or even in a building, there's so much more that we do. It does fall on our shoulders as clinicians, not to mention the scheduling aspect of everything as well. We do have our annual compliance training that is done via Paylocity. If you ever feel as though you need additional training in some particular area, you can reach out to me. We have other trainings that can be assigned to you in Paylocity. As far as an annual training that goes over the processes, we just revamped our onboarding system. Melissa, you were with me whenever we did the initial training. I know there's a lot on those first 2 days. It's a ton, but I try to be a contact for anybody in the first few months of working with us to make sure if you're uncomfortable with anything or have any questions that I'm there. Annie's there. You're registered, your PTOT is there for questions and stuff. So as far as having a training on everything that we encompass in our therapy meetings, no. I mean, we try to provide that training in the beginning before you get out there. And then we also have our annual compliance training as well as our skills training annually. But I don't think we have anything to encompass everything that we have to do. It is a lot. I agree with you. But we don't have anything yet.
It's a big part of having these meetings because we're watching out in general. And when we see trends where it seems like, oh, this is starting to slide, we bring it up. And then absolutely individually, if we see that people are struggling in certain areas, then I reach out and kind of see what we need to get that amended. So certainly if you're catching yourself, you feel like you're confused or uncertain about certain things, please reach out to us and we'll absolutely get you whatever education or practice or training that might be needed.
Yeah, and this is not a question about me being confused. It's just me listening to the call. It just seems like we're talking about the same things, and the knock is a big thing. And I was just wondering if it was compliance training, it may fix things. It may help things.
That is part of the annual
just wondering.
compliance training as well that we have in Paylocity that you do have to do yearly.
Okay, and when I mean, I just
I don't
started
think
this
the
year,
NUMNOC's
so.
not included in that annual stuff. That's just like those mandatories,
Maybe I'm
Alzheimer's,
confused
infection
because of
control,
my
all of that.
contract people have a
We do,
training.
we do have, training that was sent out at one time for the NUMNOC. Melissa, that may have been, I don't remember your hire date. So we do randomly send stuff like that out. And actually talking about that for any of the evaluating therapists, we do have some Paylocity education that's going to be coming out for the M1800s and the GG items. It's so I'll be watching for that for the evaluating clinicians. But I think, Melissa, we don't really do like something regularly. Like if we've sent it out, we don't want to, keep sending it out because, then the clinicians are like, I've already done this kind of thing, but it's not a bad idea. I can look at, putting something together for like any clinicians that have come on since the last time it was sent out. That's a really good idea. And thank you
Okay.
for bringing that.
Okay,
the
thank you.
table.
And Annie, if you can show me where that is, I mean, I don't know when I'm due for compliance training, but I started in May, so.
You will
I
get
So
mean,
an
it's
you,
alert.
something that
you did yours when you started.
Okay, so when
So
would that be due again?
You won't get it until, we'll reassign it in January, that's a really good point, is if you've not done your annual education yet, it was assigned back in January. The day that we had the ice storm, I hurried up and assigned it to everyone because I thought, oh, here's a chance, everybody's at home. You can get some time in by doing this. And we are only at, I actually have that up because I'm working on it for our meeting. And let's see, where's my, hold on. I'm getting there. As of, I don't have September's number yet, but as of August, we were only 65% completed with our annual trainings. And they were assigned like second week of January. So please jump on and get those done. If they're not done by the end of the year, we do have to look at, holding visits back because that is a regulation that if they come in and do a survey, they're going to want to look at our files and make sure that you've got those done within that year. So please get those done.
And Paylocity does send out email reminders is the big way that it communicates with you guys. So
We have
those
a
have been some really
question.
Yeah,
excellent
Melissa,
questions.
yes, if you're doing those annual trainings, you do get paid for that time that you are doing those. Yes.
Home health training. Does anybody else have any other questions? They've been good questions so far. And then I would just also ask Angie or anybody else that's on the call, did they have anything else to add? Nope. Okay. Okay, thank you to everybody who logged in with us this morning. Have a excellent day, and if we don't talk to you before, have a good weekend. And thank you very much. Talk to you later.